Ladies and gentlemen, welcome to the program, Power of the Pen, Health Easy Underwriting. For this webinar, attendees will be in listen-only mode. If you need technical assistance, please submit your request under the Tech tab in the window in the top right-hand corner of your computer screen. If you wish to submit a question during the presentation, please use the Q&A window in the top right-hand corner of your computer screen. Presenters will do their best to answer your questions. However, due to time constraints, not all questions may be addressed during this webinar. Presentation will now be turned over to Jean Lefevre.
Good morning, everyone. How is everybody on this bright Thursday in Minneapolis? We're very excited to present today's topic, which is on underwriting and the latest in underwriting trends. And we hope you'll gain further insight into really what's involved in the process. Health Easy's been at the forefront of independent TPAs in terms of staffing a full-service underwriting department. And we have the ability to underwrite cases in-house, and we can turn quotes around as quickly as 24 hours if we need to, if we have the information. And we also market out to numerous global A-rated stop-loss carriers. So this is very unique, and I think it's very timely to present this topic as we head into, I think, what we call the crazy season, the busy fourth quarter. And today we have two expert presenters. We have our very own Chief Risk Officer, Eric Lamotte, who many of you know. And then we also are very pleased to have Arlie Kennedy, who is a senior executive with Accurus Solutions today, who has broad experience with a number of carriers and really has some great insight into what's going on. And so we're very happy to have her input today. So there are a few things that we're going to focus on. And the first is really carrier perspectives have changed a lot. And so we've kind of transitioned into a world where we're hearing about a lot more catastrophic claims. Certainly high dollar drugs, which there are a number of different solutions to address those. There's greater access to data. There's use of artificial intelligence. And then, of course, COVID, which we've all lived with. So we'll get Arlie's perspective on how this has changed, really how underwriting is done. And so that'll be the first part of it. And then secondly, we'll get into the area of medical underwriting, which sometimes takes a lot more time and is more involved in how that works. At Health Easy, we're very fortunate to have our own care management team, our own medical director, and our staff of nurses, so we can easily get involved in analyzing the risk and help the underwriting process by having inside information as to what is appropriate treatment and what are those costs. So it doesn't always mean that a group that might have higher claims is not a good candidate for partial self-funding. And that's where, again, I think we have some great advantage into digging into that data to see what we can do and if it makes sense. And then lastly, we have both some Health Easy statistics as well as what Accurus is showing in terms of what claims are the types of claims that are hitting those specific deductibles, what type of diagnosis, what can you do to try and alleviate those. And so that is the content for today. Again, feel free to send in your questions in the chat box, and we'll get to those later. And I also want to thank both Accurus Solutions and Nationwide. They have been the platinum sponsors for our 2021 Easy webinar series. And with that, I will turn it over to Arlie Kennedy. Thank you.
Hi everyone, how you doing today? So I just wanted to share some thoughts just about how the perspectives in underwriting are changing from the carrier's point of view. So, we had our traditional underwriting methods where we looked at claims, we looked at large claims, and we tried to predict the risk and the ongoing risk when we were underwriting. Our perspective is certainly changing as our access to information is changing. There's a lot of great AI carriers out there who are doing some good things with AI and machine learning to try to get us data that before didn't exist on fully insured cases. So we're starting to get a little bit more creative using some of those tools. There's a few different vendors out there now that are also obtaining EOBs, so we can get the data that we never were able to get before on fully insured. So we're just looking at things a little differently. And with the introduction of RBP, it certainly has changed the way we price. We always looked at things from a top-down level. We always looked at the manual and discounted down, but that's just not how RBP works. So it's really changed our philosophy and how we look at pricing stop loss. Previously, when we were going through risk, we would predict your claims. We would go through and try to predict what your ongoing claims with some trend was going to be. And then our real focus was on those catastrophic claims because those are the things that will affect the stop loss carrier. And we always sort of before just looked at it and said, okay, what are the claims going to be and can we set a laser to try to mitigate risk? But now we're sort of looking at other things. Is there a way to get a vendor in there to get the claim paid for? Is there a way to mitigate cost? Can we steer to a better quality, better cost facility for this person? So we're really starting to still looking at those catastrophic claims, but looking at them differently, not looking at them just to say, what is that ongoing risk going to be? Trying to say, how can we mitigate that ongoing risk? Whether it be something different than just a laser. And that leads to my third point, which is that carriers are much more engaged in providing value adds. So at AccuRisk, we really look at, are you using a PBM that's pass through? Are you using a narrow network with a nurse navigation? Are you using a vendor that helps to mitigate costs on specialty drugs? We're really looking at those value add cost containment type of solutions. And that really is driven by the partners that you choose. Some of that is about choosing the right vendor. So looking at vendors that really are, everyone will call you up and tell you that they can save you money, but can they prove it? So we've started working with select PBMs, for instance, and sending over claims and saying, what would these claims have been if you had had this case? So really starting to dig into ways that we can really save cost, which across the board helps all of us. There's also some creative SPD language around specialty drugs, around transplants that really can also impact the claims. So we're looking at things like that a little bit more deep when we're looking at the underwriting. And again, I mentioned a little bit the nurse navigation. And I think everyone thinks of nurse navigation as just the getting the person to a low-cost facility, but that's really not the only thing. I mean, they do look at cost and quality when they're looking at steering, but the other potential is, can we work with a PBM where we can get in front of a high-dollar claim? So if we get notified of a diagnosis that is something that could potentially require a drug, which we know is costly, can we work with the PBM to try to mitigate that cost, whether it's getting in a vendor that can get us the drug somewhere else for cheaper, just going international sourcing, whatever it be. But that nurse navigation can be key on the RX side as well to driving those claims to a vendor that can really help us to contain cost. And at the end of the day, it really plays to the better we can manage a claim, get in front of the claim, the better the outcomes are. So we all know that if we wait until a 50% report comes in and a claim is already at 50% of their specific deductible, there's not a whole lot we can do. So it's really getting in front of the claim before it even becomes a claim to potentially reach out and get a savings before we're even seeing it as a 50%. And, you know, I think that I'll talk a little bit and then I'll turn this over to Eric. But the real strong partnership between an MGU and a TPA really is all of this. This is kind of where it all comes into play. So, for instance, sharing data integration. Is there our TPA partner? Are we allowed to source information from them directly, get information, share information from them directly? And how quickly are we notified of claims? That really is how efficient we are able to be on cost and claims, as well as reimbursements. You know, how quickly are they paying those claims? It's really taking that long-term perspective as far as the partnership between TPA and MGU. And Eric, I don't know if you want to turn this over to you, and then you can talk a little bit about this and then move to the next topic.
Sure, sure. Thank you, Arlie. I was enjoyed the valuable insights that you're able to provide. Our relationships at HealthEasy with AccuRisk and the other stop loss partners we work with is something that I care greatly about. When it comes to plan cost, ultimately actual claim spend and the claims trajectory are the determinant factor, both short term and more importantly long term, and in the plan's viability and the ultimate success of the plan. Unless you're a large employer, there can be a significant variance, especially in the short term, from one year to the next. And the primary role of stop loss insurance is to smooth out those variances, which is why it's critical that plan administrators such as HealthEasy and the stop loss carrier be closely aligned. At the renewal time, HealthEasy goes out to the market to find the best reinsurance. Once a year, we go through that process, but then throughout the year after that point, the alignment between the carrier and the administrator is essential to provide seamless service to the employer, and also to give a good overall value to the employer. As you alluded to, a couple of examples of this alignment are in data integration and in shared resources, which have become much stronger over the past 4 or 5 years. Based on the nature of stop loss insurance, in the past, the stop loss carriers were often the last to see the data. Now that gap has closed greatly. The benefits of this for our trusted advisors and for our customers is a more efficient claims reimbursement process, more involvement with the cost containment solutions as you just talked about, and a faster underwriting process. Most importantly, our key stop loss partnerships share our long-term view towards medical plans. There's an expectation that there will occasionally be some large claims that have a negative impact on loss ratios, but putting in place the right appropriate cost containment solutions will maintain a strong performance for the full block, which allows us to provide very competitive renewals to customers, even in some cases after a bad year. Next, I'll walk through a couple examples of customer successes and what a long-term approach to the medical plan can look like. The graphs on the screen may be a little hard to read, but this first example is an employer that moved from fully insured to HealthEasy back in 2010. At that time, they had around 400 employees on their plan and have since grown to around 1,500 covered employees. And the graph on the left is a good illustration of the difference between fully insured and self-funded. It represents a total of what would have been spent over the past 11 years fully insured. So this employer would have spent around $115 million over the past 11 years fully insured. And in the self-funded model, their fixed costs at the bottom of the graph have cost them around $15 million of fixed costs instead of $115 million. And the rest of their spend is whatever they spend on claims, their actual spend on claims. When you add in what they have spent on claims, they spent around $86 million compared to $115 million, which is around a 25% savings that they've seen under a self-funded model. This next slide is the same employer. It's just showing their savings over time on a cumulative basis. So as you look at this graph, you can see at the beginning, their hard dollar savings looks relatively small, but then as you move along over the years, the gap starts getting bigger, and that's a common trend that we see over our customers, is that the longer that our customers stick with this model, the greater their savings increases on an annual basis. The final graph on this illustration highlights why that is. The top line on this graph shows what this employer's cost would look like on a per employee per month basis if their spend was increasing at 5% a year. So that flat line, or the diagonal line, is just a 5% increase per year in premiums. And the bottom line is their actual per employee per month spend over the years. At the beginning, they had some large savings the first year, partially because it was an immature year. So you have 10 months of claims rather than 12 months of claims. But then as you get a couple years in, you can see the line in actual spend is much flatter than even a normal smallish fully insured premium increase. And that's a direct result of this model and having an independent administrator who's able to work in collaboration with the employer and the stop loss carrier. One other example that we have to walk through is a 50 life employer who's been with us for 11 years as well. This particular employer would have spent close to $6 million over the 11 years, much smaller size. So it's the opposite end of the spectrum. So this is to just sort of give an example that both small and large employers can benefit from the model. Based on size, this employer's fixed costs comprise a larger portion of their spend than a larger employer, because a larger employer is able to take on more risk on a per person basis. But the actual savings at the end of the day for this employer was even greater. Their savings is just under $2 million over an 11-year stretch for a 50 life employer. So compared to fully insured, it was over a 30% savings. Switching gears, one of the largest areas of anxiety when talking to advisors or employers around self-funding can be the medical underwriting process and lasering. And it's often one of the areas where we get the most questions, which is why we wanted to address in today's webinar. The term lasering can be perceived with negative connotations. The process of underwriting self-funded plans is to take an employer's data, assess the risk of the employer, and provide two parts: premiums, which are fixed costs, and then a max claims liability to set a cap on what the employer might spend. And the employer pays the premiums, and then the rest of their spend is whatever their actual claims are. Because the premiums in a self-funded plan are greatly reduced from what an employer would spend in a fully insured plan, the intensive stop loss premiums are to cover unknown risk. A laser is taking a known large claim and assigning special contingencies to one claimant because of those known ongoing medical issues. These dollars that of a large claim need to be accounted for in the underwriting process, and they can either be attached to a fixed premium, like they would be in a fully insured environment, or those costs can be taken and put into a variable expense or put into the client's claims bucket. The employer, in many situations, can benefit from these dollars being put in a claims bucket rather than as a fixed premium, as the claims do not always materialize or incur. So if the costs are in the claims bucket and they do not materialize, the employer does not actually have to spend those dollars, versus if they're a premium, then you have to spend those dollars. Lasers are assessed and determined in the underwriting process and evaluated and shopped among multiple carriers. Once the coverage is established for the year, additional lasers can not be placed until the next year. So this is just done during the initial underwriting process at the beginning of the year. Prior to moving on, I know Arlie has some thoughts on this topic as well, so if there's anything that you would like to add in, Arlie, on lasering, go for it. Oh, I think you're muted, Arlie.
Yes, I am. Thank you. So the word laser used to be like the dirty word. No one wanted to hear the word laser. But when used effectively, it really can be a benefit to both the client and the carrier. Basically, it allows us to be more predictive on risk. Some of the most common things we see as far as lasering are your cancer treatments, heart, people that are on maintenance drugs that are going to continue to be on maintenance drugs. Those are all things that we can predict. The things that are a bit trickier are things like cancer, because the therapeutics are constantly evolving. So it's very hard for us to predict the cost risk on some of those, because it's always changing. I would say that about a third of the lasers that we set on our groups do actually hit. And it's also more effective. Lasering is more effective on groups with a smaller specific deductible than a larger specific deductible. If you think about it, if someone's on a maintenance drug that's going to run $50,000 to $75,000 a year, and your group specific deductible is $50,000, that person's going to continue to hit year over year. So using that laser, you can predict what your cost is going to be, and we can predict what our risk is going to be. As well, at the higher deductibles, if someone runs at $250,000, say a year, because they get some treatment, typically that person isn't going to hit year over year. So it's not usually something that is going to be something that we're going to see at the higher amounts. So they're all also can be very effective. The hardest one really has been, or the hardest hit to lasering, and why we're seeing it more often, is really that specialty drug space. So a lot of these drugs now are just skyrocketing in cost. And so again, as I sort of talked about earlier about cost containments, that really is why it is so important for us to try to mitigate that specialty drug risk. Whether it's a use of, sometimes on some of our cases, they carve out the specialty drugs to a vendor that gets them, either takes 100% of the risk or helps them to get the drugs for a discounted cost. But those really probably have been the largest challenge in the laser space for us. I would say too that you'll hear a lot about no new laser. The evolution of that really started probably in the early 2000s. At that time, I was working at Sun Life, who was a carrier, and they were very pro doing no new laser. And at that time, it was before healthcare reform. So there were limits on lifetime maximums. So it was a very easy thing to do, because someone wouldn't repeat year over year, and there was some prediction on what that cost was going to go. Well, with the introduction of healthcare reform, no new laser has really been a harder game to play, because somebody can just continue to rack up millions and millions of dollars of claims year over year with no type of cap. So it's become a lot more challenging for carriers to offer that. Most carriers, I really only think there is one who will do it evergreen. What I mean by that is, it means that year over year, they continue to not laser people. Most places will do it. Most carriers will do it as a year to year. We'll look at the risk on a year and say, okay, we don't need to laser anyone going forward. You're okay for another year. So that is sort of how it has evolved. But from an employer standpoint, sometimes it's beneficial to not have that protection, because you are paying for it. It is something that, if there is a known risk, yes, it can save you money, but you're paying for that protection year over year. And sometimes it can be 8 to 12% of your premium. So it's really a risk reward type of situation. And a lot of employer groups just decide that they don't have the catastrophic claims that they really feel they need to have that protection year over year.
Right. Moving on, we have a couple examples, and it might be hard to see on the screen, but I'll just talk through them, of some of our customers who did have a situation where they had a member who was lasered, and to where it actually benefited the employer to have the laser in place versus paying higher premiums. This first example is an 87 life employer, and they had a member who was on Stelara for psoriasis. And based off the cost that it was coming through at, it had a $90,000 laser. So this employer, prior to the medical underwriting process, was looking at a 4% increase on their overall fixed costs and a 10% increase on their max liability. Because of that additional exposure during the medical underwriting process, it increased the renewal to a 14% increase on max liability, but their fixed cost, because of the laser, stayed at a 4% increase, so they had no increase on premiums. If they would have went with the no laser option, and the carrier was trying to account for it in premiums, they would have been looking at a 16% increase in premiums potentially, and still have that 14% increase in max liability. With this particular member, we were able to find a vendor who was able to source the drug through an assistance program, and get those costs deferred from the health plan, so that the plan ended up spending less than their deductible of $50,000 during the year. So even though the laser was in place, they did not spend more than their normal specific deductible of $50,000. And also they maintained that 10% max liability at the end of the day increase, and the low 4% increase in fixed costs. So in this situation, they saved that extra premium dollars, and they did not spend the claims. And we had one other example, and this is another example of a drug cost that was leading to a laser, but this example, the drug cost was coming through as a medical claim rather than a pharmacy claim. This group had a child who was on Remicade, which is an expensive injection, and the child initially had to receive the injection through a medical facility based off their age and medical situation, and the cost of it was coming through at around $125,000 a year, which is where the laser was established, and this group had a $50,000 deductible. So the group initially was looking at a flat renewal, but then that laser kept their fixed costs at the renewal they were at initially, but based off the additional claim exposure, pushed it from a flat renewal to potentially a 17% increase. We were able to work with our medical team and the stop loss carrier to make the laser conditional, as we had sourced another location where the member could receive the injection that was at about a third of the cost of the facility that they were initially at, which dropped the cost under the group's deductible. And so we were able to make the laser conditional in the underwriting process, where if the member moved from the hospital to the clinic, that the laser would not apply. And then our medical management team was able to execute that and have the member's location moved. So it's an example of how the medical underwriting process is a collaborative process, and if we're able to work, as Arlie had referenced, with vendors or different other cost containment approaches to mitigate the costs, you can often mitigate some of the impacts of lasers. Moving on to the last area that we are going to cover in today's webinar, sort of a good lead-in from lasers is the topic of large claimants, and just sort of give people an overview of what types of claims are really driving the plans from our perspective. And these affect both the spend that the employer is spending, but also the loss ratios for the stop loss carriers. These first few slides are some stats from HealthEasy's book of business. And a couple of the graphs up here, a couple of pie charts, show the most recent 12 months on the left compared to the prior 12 months on the right. And if you're able to read those numbers, what you'll notice is from one year to the next, when you're looking at it across our whole book of business, it's almost the exact same experience. 97% of the members with Health Easy have less than $25,000 of claims. And then about 3% of members have between $25,000 and $150,000 of claims. And then 0.3% have over $150,000 of claims. So a lot of times people talk about the 80-20 rule, 20% accounting for 80% of the dollars. But really what we see is, as I switch to the next slide, 0.3 of the members are accounting for 20% of the dollars on claim spend, and really 3.5% of the population is accounting for nearly 60% of the claim spend. So as we're talking about some of these cost containment approaches and ideas, really what everybody's targeting is that 3% of the population. Some of the cost containment approaches out there are targeted, where those sort of 3% of the people that are incurring those dollars are the ones that are impacted by the solution, sometimes positively, a lot of times. A lot of times the members can save on their own out-of-pocket through some of these solutions, but that's who's really being targeted. And then other approaches like reference-based pricing is an example, is also targeting those 3% of people, but they affect everybody in the group potentially. And similar to a wellness program, a lot of times, when a wellness program is put in place, it's, one, to provide employees that opportunity to have, help with their wellness, but it's really trying to, address the 3% of the people before they get to be a large claim. This next bar graph shows on Health Easy's book of business how much dollars are falling under individuals who have between $25,000 and $75,000 of claims. So on a typical stop loss policy, these are largely the claims that would be driving the aggregate expense in the group, or the bulk of the claims expenses that the employer is covering. And so about half of the dollars are they're just spread across many diagnoses. But then the biggest individual drivers are musculoskeletal, gastroenteritis, cardiac diseases, and then pregnancy. One final graph before we get to the last slide. Claims over 75,000. So these are the types of claims that we see that really impact the stop loss premiums. These are the dollars that largely the stop loss carriers are paying out their claims on. And in 2020, in both 2020 and 2019, close to a third of the dollars over $75,000 are under cancer-related diagnoses. In 2020, almost 15% were infections, and that was an aberration due to COVID. If you look at 2019, it was under 5%. So that's where you can see the impact of COVID on stop loss claims. And then the other sort of common categories here are cardiac disorders, again, neurological disorders, and then stomach disorders, which a lot of times that's where you'll find specialty drugs under the gastro disorders. And I'll hand it back over to Arlie, if she has any thoughts on these claims as well.
Yeah, so I would say that from our particular perspective at AccuRisk, the most common claims that we see go over are things that are for maintenance type of drugs like your Crohn's or your MS. And then we do see the catastrophic cardiac and cancer claims that we cannot predict. And always your premature infants, those are very, very hard to predict those happening. So those are the type of claims that we see come through as stop loss claims most commonly. And so what we really try to do is mitigate them. So as soon this, again, like I talked to earlier, the sooner we know about a claim, the better. It really benefits all of us across the board. If we can get ahead of a claim, if we know that someone has been diagnosed with Crohn's and is going to start on a high dollar drug, and we can try to get it for less expensive between the relationships that we have, the relationships that Healthy Z has, to try to mitigate cost on that, it really can be effective, which benefits the employer, it benefits the stop loss carrier, and it makes your relationship with Healthy Z a little bit stronger because they're finding these cheaper alternatives for you. So really, mitigation and approach to claims is really the key to success as far as controlling costs. Just a word or two about the impact of COVID. I think that, when COVID first hit, we all thought, oh, well, everyone's not going to the doctors, and all of a sudden we're going to see this huge escalation of claims later in the year. And we really haven't seen that. We really didn't see the claims escalate at the end of 2020 like we anticipated it. It's sort of leveled off, I would say, and has been sort of continuous. As far as what we're seeing for claims with COVID, at first we were seeing a lot of high dollar claims, but I think as we learn more about how to treat it, the cost has come down significantly. You're still going to get your one-off type of things where someone reacts to the virus and there is a higher cost, but really it has leveled off as we've learned more about the virus. So that's all I've got. So with that, I'll turn it back over to Jean, and we can maybe start a little bit of Q&A.
Great. Thank you very much, Arlie and Eric. Always good to get kind of the inside view of what's happening, because we all have, I think, our perceptions too of what we think is bad risk, but a lot has evolved. And of course, interesting to hear about the use of artificial intelligence and the data that's out there. It's a little bit, could be considered big brother-ish, but definitely helpful, I think, to get at that and kind of evolve how underwriting should work. We do have a few questions here, and I think the first one that we have would be for you, Arlie. So what is your position? I noticed that on all the diagnoses that you both talked about, no mention of transplant. So would you recommend that a group have a fully insured transplant policy and carve it out of the self-funded plan, or what's your view on transplants?
So that's a good question. What I would say is there are a couple of different options. Always carving it out through a fully insured transplant program is an option. Again, it really depends on cost, right? So if you have never had a transplant or you don't have anything emerging, you might think paying extra to carve that out is maybe not you're willing to take the risk of having a transplant versus paying every year for something that you're not using. The other option is to really well manage it within the plan. So there are some centers of excellence that you can add into the plan. There is nurse navigation that you can add into the plan to really drive that to a cost and care facility that will be within the network and will get us the best discounts. And the other option, the alternative that I have seen, is some creative plan doc wording, controlling the cost, whether it's through RBP, whether it's somehow limiting it to Medicare or a percent of Medicare. There's some really interesting things being done within the scope of the plan documents to control transplant costs. So it really decides, do I want to try to be creative and control the risk within the plan, or do I want to carve that out and totally not have that risk? It's really what your appetite is. As far as the risk, it's definitely always something that comes up, but there are ways that we can talk about controlling it.
Great, thank you. The next question, I think, is probably for Eric. And so does Health Easy provide no new laser contracts?
Thank you for that question. The short answer is yes. The longer answer would be each carrier that we work with, for the most part, looks at it on a case-by-case basis. And generally, a group has to have a certain amount of premiums before a carrier will consider it. If the premiums are too low, there's not enough premium for a carrier to put in a no laser policy. So what we see is, once the premiums start getting on the plan to close to 250,000, 300,000 or above, carriers will start looking at being willing to place a no laser policy on a group. And our recommendation would be, if it's something that a group is interested in, for the safety of the no laser, is to really look at it to see if it makes sense, because it's about a 10% increase on the premiums typically, and then a rate cap of what they can increase the premiums by, from 45 to 50% often, 40% is it sort of 40 to 50% is a typical range. So there's sort of a sweet spot where once you're in that sort of 250,000 to maybe 500,000-600,000, there may be situations where the no laser makes sense. But then if you get to be much larger than that, that 50% rate cap on the premium becomes a really big increase in premium. So it really would offset a likely laser that would be in place anyways. So you sort of start losing value if an employer gets large on a no laser contract as well. So I would recommend just sort of looking at it and not just jumping to the no laser because it feels like the safe thing. You also, if you're looking at self-funding as a long-term approach, and you look at we're going to have a few large claims over 5 to 10 years, the no laser doesn't make as much sense as if you're looking at it on a short-term basis.
Well, and I think you demonstrated, at least with a couple examples, and there was information about, a laser may be a good thing because you're keeping the costs much lower for the rest of the population. And I would assume, if you do buy that policy and you pay extra premium, your renewals sometimes are based on that. So are you then, if you're getting a 5% renewal, is that on top of that higher cost, even if, that person who was considered needing a laser is off the plan? Is that a fair assessment?
Yes, and also from my perspective, it's always hard to get carriers to give a decrease on premiums. So if rather than a laser, you absorb a higher premium, then when that claim's not ongoing in future years, you're sort of at a higher premium threshold, and it's hard to get the premiums back down to where they were originally. So that's another benefit long term with lasers.
Well, we certainly try to get that, but yeah, it is hard to do. I think we have one more question here. So we talked about turnaround time, and as we get into the busy fourth quarter, which we're all crazy, working around the clock. So what can we expect both from Health Easy as well as Arlie, if you want to weigh in on turnaround time for quotes?
Yeah, I can start from our perspective. As Jeannie mentioned in the introduction, we have a full underwriting team in-house at Health Easy, which allows us, if we need in the fourth quarter, we can turn quotes around in 24 hours for a preliminary. Based off the data, if there's more questions or information that's needed, there may be additional follow-up information to firm up a quote or lock it in. But to get an initial assessment of the case, we can turn quotes around in 24 to 48 hours.
Yeah, and I would say, the cleanness, I guess I would say, of a case and how we receive it really affects how the turnaround is. So if we get a case and we have to keep going back and forth to get more information on a case, that can definitely drag things out a little longer. I'd say that in our really busy time, our standard turnaround is 3 to 5 days. But I would say if we need something faster, as long as we know that it's something that all the information is there, we can do that. And the benefit of working with the partnership with Health Easy and AccuRisk is that Health Easy has the ability to do some of the front end underwriting for AccuRisk on behalf of AccuRisk. So they can sort of do that front end stuff and turn it around for you really quickly, and let you know whether, hey, this is going to be a good option for you or not. So that does save a lot of time as far as when it comes to the busy season as well.
Great. Thank you very much. Thank you, Arlie. Thank you, Eric. Great information. I hope everyone will join us for our next webinar, which is on Tuesday, September 14th. And we're actually going to feature many of our Health Easy team members. We think we have the best team in healthcare. So we hope you'll join us. And thank you again to our sponsors, AccuRisk Solutions and Nationwide Insurance. Have a great day.
Thank you.
Concludes today's presentation. On behalf of the presenters and HealthEZ, thank you for joining.